Okay, good morning, everyone. Hopefully everyone's having a wonderful Saturday morning, bright and early at 8 a.m. Pacific time. Welcome to Saturday to the 2021 Eastern Oregon EMS Conference. My name is Sean, and I'll be your online moderator through the day. Before we get started with our first session this morning, I just wanted to get through a couple of items. The first one is if you are at an agency and you have multiple people watching the same screen, that's great. What I recommend to keep track of that is just create your own internal training roster. That'll be a better roster to keep in case anyone ever gets audited for who attended. You can attest with your own personal roster. The next item is if you registered and then shared your link with somebody else, we just see you twice, whoever registered, because that's unique to you. We won't see anybody else as being registered. So if anybody wants to be uniquely registered to get the unique certificate from the GoToWebinar facility, you need to have your own registration. And you can register at any time. Next item, we do have a YouTube channel. So yesterday's presentations, I have the first one up. During this, I will get the other two from yesterday up. It takes an hour or two for them to get to us, but probably by tomorrow morning, we'll have all of the presentations from yesterday and today on our YouTube channel, and that's just the Eastern Oregon EMS Conference YouTube channel. For those looking for the certificate of attendance that comes from GoToWebinar, be patient. It automatically sends them out, but it sends them out roughly an hour after the end of the presentation. So if you haven't seen it within an hour or two, then let me know. But other words, it takes just a little while. On that certificate of attendance and also in the course descriptions for each of these is the state of Oregon CEU category where these fit into. If you're from another state or using it for registry, apply to where you see it fits. We are not an accredited CAPC or any of that organization. So to be used for CEU, all it needs to happen is it has to be approved by your medical director, and then you're good to go there. Through the presentation, you can either put in questions if you have questions, or chat if you want to send us a chat. You can also send in messages on our Facebook page via Facebook Messenger. We are monitoring all three during the presentations. After the presentation starts, if you want to be able to see the full screen, you don't want to see that little chat box, there's a red arrow that points to the right. Just click on that, and then we'll minimize that chat box, and then you can click it back to the left if you want to open it back up to ask questions. Don't forget to register for the other 6 sessions that are available today. Towards the end of each session, we do put up the link for the next session in our chat box, just in case you hadn't registered yet. And last but not least, audio. If you're having issues with your audio, you can't hear me right now. But there are, if you know folks are having issues with their audio, there is a link on the GoToWebinar site that helps you troubleshoot any audio issues you might have. Usually it's just what output you are using. So with that being said, I'm going to stop my presentation here and pull up Dr. Lehrfeld and hand the controls over to him and allow him to introduce himself for this morning.
Okay, how are we doing?
You sound good.
Any visuals come across yet?
Yep, you are up.
Let me just swap views here. All right, thanks a lot for having me. My name is David Lehrfeld. I'm the medical director for the Oregon Health Authority EMS and Trauma Systems. I'm sorry we're not all out at Blue Mountain College doing this in person with our cadaver labs, but as they say, we live in interesting times. So again, thanks for having me. This is OHA updates. And all we've been doing at the OHA for the past 12 months is COVID-19. So the update is mainly going to cover that, but we'll talk a little bit about regionalization, wildfires, the winter storms, and a little bit about EMS modernization going forward. Hopefully at the end, we'll have time for some questions. So let's jump right into what has occupied all of our life for the past 12 months. The stupid coronavirus. So what is a coronavirus? Coronavirus is a large family of RNA viruses that are common in many people, many different species. In fact, camels, cattle, cats, bats. It's the second most common cause of or I should say the second most known cause of the common cold, to include rhinoviruses, influenza viruses, RSV, others. All these viruses are respiratory viruses, so they're spread by respiratory droplets, sneezing, coughing, etc. But this is a novel coronavirus. What do we mean by novel? We mean that it's never existed in humans before. And let's see how novel viruses, especially novel coronaviruses, differ from our old friend, the flu. So this chart right here, I want to point out three things. If you go to the second row, you'll see something. There's a large R, a CFR, and an incubation time. This R is called the R naught. It's the theoretical reproductive value. And that's how many people could be directly infected from one case in a population where everybody was vulnerable, right? And that's one of the key things to novel viruses like H1N1 or the SARS-CoV-2, because it's never existed in the human population before, everybody is vulnerable. Nobody has antibodies towards this. And this is an exponential value that changes depending on what we do about it. So you lock down hard, that number goes down. You don't lock down at all, that number goes up. But that number is super important because it explains the veracity of respiratory outbreaks. This is an exponential number, and just to illustrate this, this is 10 cycles of the virus spreading from one person to another. And if you look at the flu, whose R naught is in the United States typically 1.3, versus COVID just a little higher at 2 at the low end, after 10 cycles, you're talking 56 people sick versus over 2,000 people sick. And this explains what you see in LA and in Houston, especially in New York City with the high population densities. Once these respiratory viruses get out of control, they just go everywhere. The other thing we want to look at is the case fatality rate, right? You'll see in the, it's rather low in the flu, although it still does kill millions of people yearly and tens of thousands of people in the United States. But if we look at something like SARS-CoV-1 that had about a 10% case fatality rate, 1 in 10 people would die that got it, and especially MERS with a 34% case fatality rate, 1 in 3 people that get it. Viruses with very high case fatality rates tend to burn out really quickly because they kill their victims before they can spread too much, right? And that's if you see at the bottom annual infected numbers, they're rather low compared to the flu, which has a very low case mortality rate. And SARS is sort of right in between there. It's deadly enough to be worried about, but it's not deadly enough that it's going to burn itself out. And the last thing that makes this novel coronavirus so difficult to get under control, besides its R naught value and its medium case fatality rate, is it's got an extremely long incubation period. And you can see that on this table compared to SARS-CoV-1 and MERS and the flu. And just to illustrate this, if you get the flu, you usually feel sick within 24 hours. And you know, you're sick, you know you're going to do the right thing. You're not going to go to work. You're not going to go to school. You know, you're going to wash your hands, et cetera, isolate. But with COVID-19, you can be sick. The incubation period can be up to 2 weeks. So you can be carrying the virus. You can be spreading the virus without knowing you're sick. And this was, you know, we see illustrations of this all the time. There was just I forgot what city it was in, but there was a spin class where the instructor came in. Nobody's wearing masks because it's a highly aerobic activity and it's really hard to do highly aerobic things with masks on. And the instructor was, you know, facing all the students, of course, shouting encouragement at them. And the instructor went home about 2 hours later, started feeling sick. And wouldn't you know it, every single person in the entire class was infected. So that makes this pretty hard to control. Within 12 months, even with, I'm gonna say limited spread, I'm using air quotes because, you know, there's been various strategies of lockdown in places that were more effective and more severe than others. But even with everything we've done in 12 months, we've lost 500,000 people. So that would make this at this point about 33 times more lethal than the seasonal flu, even though it pales in comparison to SARS-CoV-1 and MERS. So where are these viruses coming from and why are they so lethal? Well, SARS-CoV-1, bats are a giant reservoir for coronaviruses. Sometimes these coronaviruses need to mutate to an intermediate host. So for SARS-CoV-1, there was genetic evidence that it went from bats to civet cats, which are like Asian weasels, and then into humans. And MERS, it went from bats to dromedary camels. It was at first thought that SARS-CoV-2 went from bats to pangolins. If you don't know what a pangolin is, Google it. It's probably one of the most awesome animals in the world. But because they had found a pangolin virus that was very similar to SARS-CoV-2, but they later found a bat virus, RATG13, that was even more similar. So at this point, we think it went mutated directly from a bat into humans. But it's not just coronaviruses that do this. You remember the bird flu H5N1 with a 60% case fatality rate, which makes MERS even seem tame. And then there was the pig flu H1N1. It had like a 0.5% case fatality rate, more like the normal flu, just a little worse than the normal flu, although it never really took hold in the United States. So these crossovers from humans to pigs to birds to other animals that get coronaviruses and influenza viruses happen all the time, but they tend to be deadly when they do. And that's because, as I alluded to earlier, we have no herd immunity to these variants of these zoonotic or animal variants to these human diseases. And if you look at the illustration here on the top, you can see one or two people get some novel virus that came over from an animal, and nobody's immune to it. So everybody gets it. Everybody turns red. When there's some immunity, it'll slow the spread, right? So you can think of the people that are yellow that have previously been exposed to this virus, and they have some immunity, but it's not enough to stop the spread. What the bottom illustration shows is herd immunity. Herd immunity either through vaccinations or because just everybody has already had it. And the immune individuals actually act as a physical barrier. They surround the infected individuals and keep the non-immune individuals from ever running into the disease. And those non-immune individuals can be people who didn't get vaccinated, but they can also just be people with compromised immune systems, people on chemotherapy for their cancer, or prednisone for their asthma. So not only does immunity keep the disease from spreading, but if you do get it, you're less likely to get really sick. You know, you may hear various statistics going around about the yearly flu virus. Oh, it's only 60% effective. And there's a lot of reasons for that, because the flu is a much genetically different virus than coronavirus. But there's a difference between getting it and getting sick enough to be hospitalized and getting sick enough to die. You know, as we can see from this, the mortality for the flu and the hospitalization rates for flu and COVID are much different, and the mortality rate is much different. We had said the mortality rate we thought was about 2 to 3 in Oregon. You know, you may have noticed we locked down harder than other states. That's going to change all those numbers. It was about 1.6% last time we checked, which equates to about 200,000 dead in 12 months. In the US as a whole, because not all places locked down as hard as Oregon, it's up to 2.83%. So what we originally estimated it was going to be based off of what we saw in China and Italy earlier on, which equates to about 500,000 dead. So the flu takes out at the top end, at the very worst years, about 600,000. So that makes this about 3.5 times as deadly as the flu, despite the lockdown. Because remember, those flu mortality numbers are nothing. When nothing is done, no hand washing, no masks, no staying home when you're sick. And just to illustrate how effective those techniques, simple public health techniques, don't come to work if you're sick, wear a mask, wash your hands. This flu season basically didn't exist, not in the United States and not in Australia over the summer. In our lifetime, we have never seen such few cases of flu globally, just from simple wear a mask, don't go to work, wash your hands. it is no exaggeration to say that the flu season does not exist this year. It just doesn't exist. So as I mentioned, case fatality rates despite the lockdown. So here's how we're doing in Oregon. This is the past 12 months in Oregon. You can see the spike was last November. There was a lot of holiday parties, Halloween, Thanksgiving, and there was a lot of travel. It really spiked. I think people saw the numbers, and you know, it had been low over the summer, right? We locked down hard in the spring, and our numbers reflect that. Started loosening up during the summer. Numbers started increasing, but really kind of plateaued. You know, in the winter months, there's the usual spread of respiratory pathogens in the winter months, just due to the weather being locked up inside and everything. But I also think we became a little complacent over the summer when we sort of plateaued in our cases. And then there was a lot of holiday festivities that really spiked us. And we came close. We almost became a New York or an LA, but I think people did the right thing and managed to get the numbers down under control. And you can see the total on the top. Those are Oregon numbers. Some of these numbers are reflecting of testing bias, because in the spring we didn't have much testing, but pretty much the testing bias has gone away. And you can see that in that plateau over the summer and into the fall, that we were able to test as many people as we needed to. And so the spike you're seeing in November is real, not just a bias on who's being tested. And by the way, you can test that again by seeing how many people were hospitalized as a proportion of the population, right? Because the people that were hospitalized were really sick, and so that would eliminate. If those numbers are similar to your overall population numbers, then it's probably not testing bias. So you can see where the current infection rates are high. They obviously follow population centers and the interstates. The gray countries are not, the gray counties or zip codes are not special magical lands where nobody gets sick. It's just the population. This is reported as cases per 100,000. So the population, or cases per 1,000. So the population rates are just lower there, and so they don't report the numbers. So this is the United States. Overall, 2.8 million cases, 500,000 deaths. It's impressive. That's 3,240 deaths per day, down from a high of 6,500 cases per day. That's deaths, not infection. Just to put that in perspective, about 1,600 people die of cancer each day in the United States, and about 2,500 people die of cardiovascular disease. And those are the two top killers in the United States combined. So at its height, coronavirus was killing 30% more people daily than both cancer and cardiovascular disease alone. It's still killing more, but not at the rate it was. So here's a comparison of states I picked that had, obviously, New York, California, high population densities, Florida, Texas, some cities with some high population densities, but also some questionable public health strategies. So Oregon looks great, right? Oregon is in yellow. The lockdown flattened the curve. Yet despite this, we came close to avoidable deaths. And what do I mean by avoidable deaths? Respiratory pathogens are going to kill a certain amount of people no matter what, right? Either you're unlucky or you have underlying conditions, or you have a genetic makeup that makes you particularly vulnerable to whatever that pathogen is. But what we're trying to do by flattening the curve is unavoidable deaths. That's to say you would have lived had you had proper medical treatment. So, and that's what happened in places like LA and in New York City. There were avoidable deaths. They just ran out of resources. And flattening the curve is trying to give us time to scale our surge strategies so there's not avoidable deaths. It came close in the third week of November. I think we were down to 4 ICU beds in the entire Portland metro area. one of our level 1 trauma hospitals had 0 ICU beds per day. And this was all despite stopping all non-emergency surgeries, shutting down all outpatient surgery centers, pulling all those staff into the hospitals to staff the beds. We still came really, really close to running out of resources. And this is the situation. Like just recently, LA County found themselves in these same months. This is it's Dr. Hill, great EMS doctor, found herself in the unenvious position of issuing directive number 6, which limited the care of out-of-hospital cardiac arrest patients due to a lack of resources caused by the COVID surge in LA. And I would like to point out that medical surge affects every part of the medical system, and it can't be isolated. The cause of this surge was infectious disease, but as you can see from this memo, it's out-of-hospital cardiac arrest was being affected, and trauma and stroke care, etc., suffers because of this. So medical surge plans must be all hazard plans, right? That account not just for the surge in need, but how the surge interferes with supply chains and staffing. In our case, when we were running out of ICU beds, it wasn't that people didn't physically have beds or even monitors or IV pumps. It was critically care trained nurses, right? Who were either themselves sick with COVID, they were burnt out from working constant overtime shifts, or, they couldn't make it into work because they had family duties because their kids weren't in school and there was no daycare. And so as we tried to emphasize with the hospital and healthcare systems earlier, you can't just plan on what your COVID surge is going to be, because if your ICU is full of COVID patients, then there's no room for stroke and trauma patients as well. So always have a plan. What was our plan? Well, our plan was to flatten the curve. The Institute for Health Metrics created this model early on when New York City was blowing up in the spring that sort of illustrates why we want to flatten the curve. So the green line is available ICU bed. The solid green line is available ICU beds. And the dashed green line is the projected ICU beds that would be needed at the peak of the infection rate according to their predictive models, right? And this is the gap that New York would have had to flatten, or the surge they would have had to implement to either raise the number of ICU beds or keep the number of infections down so their ICU beds didn't their resources weren't outstripped. We saw this all happening in the spring, before the coronavirus had really taken off here. And so that's exactly what we were looking to do, is to not end up where New York was, where they were literally piling bodies up in the Sally Ports behind the hospital every night. I think at its peak, there were over 700 hospitalized COVID deaths in New York City in one night. So in New York, or rather in Oregon, we came up with our strategy to flatten the curve, but also strategies to surge with. The document we were going off of for EMS was called Appropriately Strategies for EMS Surge, but I'm going to just use hospitals because it's a fair comparison. So it breaks it down into conventional, contingent, and crisis, and we put the green, yellow, in red there to indicate the level of severity. In your conventional phase, you're in your planning phase. So we're writing all our sick leave policies, we're writing all our surge policies, we're getting contracts for independent contractors to go in, we're inventorying all our ventilators that are offline, how often we can bring them online, extra beds that are in the basement, etc. When we cross that line, indicated by yellow, so the solid green line is our resources and the dashed green line is our projected or possible resource need. When we cross that line, we go into our surge capacity or contingent. So we're raising the amount of resources we need, right? And the difference between these two is, you turn your med surge beds into ICU beds. you bring in your extra staff, etc. But when all your surge strategies in your contingent phase have been overwhelmed at this point, then you got to go into your crisis standards, which is triaging, right? And this is allocating who's going to get what and how much of it. For EMS, we have surge strategies for EMS care, and I'm going to just X out of this real quick so you can see it. And here's the Oregon Health Authority's webpage for healthcare partners. If you Google OHA COVID, you will see this banner on any OHA page, no matter where you go. Oh, I picked the one link that wouldn't. So if you go to OHA's website, no matter where you are breezing around it, you'll see this banner. This is for the general public. This is for you guys. This is healthcare providers. And as you scroll down through it, EMS, PSAPs, and law enforcement has their own section. You can feel free to browse the therapies section, the playbooks, the vaccines. But here's where you find your COVID-19 protocols and pre-hospital guidance and strategies for EMS surge. It's an HTML document, right? And this is sort of a write your own story document. There's a short preamble about how the framework is of conventional, contingent, and crisis care standards. There's an ethical statement about non-discrimination in healthcare. And then you run into this table here on the second page, which is your index, right? And it breaks it down into across the top, conventional, contingent, and crisis. I'll make that a little smaller so you can see the whole thing. And then on the left-hand side, phases of response and other concerns such as staffing, equipment, levels of care, PPE, and regulation. And so depending on where you are in your surge response, you can just pick one of these strategies. And I'm going to just go implement emerging infectious disease screening for the medical call, right? So this would be a PSAP strategy. And you come up with the protocol if you don't have Priority Dispatch or APCO or something that already provides you with this. Will provide you with a protocol that your medical director can adapt. And at the bottom of each page, it just takes you back here, right? And all these strategies are laid out in this conventional, contingent, and crisis framework. So if you look at transportation, there's a treat and not transport, or a treat and transport to an alternate destination protocol. If you look at responses, there's a conventional, contingent, and crisis strategies for your responses that can be various, choose as it applies to your EMS system, such as no transport to code 1 calls, between healthcare facilities, activating additional swing units, all the way up to activating the Fire Defense Board and requesting the ambulance contract from the OHA. We have that same sort of framework when it comes to choosing hospital destinations. You can see here, and this is, just, I'm going to go over the general one. In conventional mode, you transport to specialty hospitals or hospitals of choice. In contingent, you may limit patients' destinations to hospitals, to their choice of hospitals or specialty centers. And then in crisis mode, you transport to the closest hospital plus or minus transfer into specialty care. And it goes over suggests, and these are all just recommendations. These are all just strategies to be adapted by you and to be turned on and turned off depending on where you are in your surge. And this goes on to go over PPE regulations, staffing, etc., and should really be adaptable by any system with modification, depending on where you're at in your surge strategies. So those are our tools to flatten the curve. We've done a good job so far. Get back. The end game is to keep things under control and keep our resources within our limits until we get the vaccine. Right? until we have a way to get that herd immunity within the population so the disease stops spreading and that R naught drops to 0.0001. And they have arrived. So in record time, in under a year and really under 6 months, Pfizer and Moderna were both able to make a vaccine towards this disease of SARS-CoV-2. And just to put it in context, most vaccine development takes 12 years. The fastest vaccine ever developed was the mumps vaccine, and that took 4 years. So this took about 6 months. And really, the vaccine development was done almost instantly because of the type of vaccine it is. It's a messenger RNA vaccine. And I'll explain what that is a little bit more, but it was extremely easy to make with pre-existing technologies. And the 6 months was really just creating the clinical trials to make sure it worked and make sure it was safe. So the Pfizer and Moderna vaccine are both messenger mRNA vaccines in a lipid capsule. They're fairly the same, but they do require ultra-cold storage. The AstraZeneca was a modified chimpanzee adenovirus, and the Johnson & Johnson uses an adenovirus carrier as well that's been attenuated to not cause sickness in humans. These viruses, the Pfizer and Moderna, have undergone safety and efficacy oversight committees in the FDA, clinical trial data safety and monitoring boards within the study themselves, which are independent review boards. The Vaccine and Related Biological Products Advisory Committee of the CDC, wonderful name, and the Advisory Committee on Immunization Practices of the CDC, who says who should get the vaccine first and why. It also underwent an additional level of review with the Western States Scientific Review Work Group, because out here we got to have our own thing. So what's an mRNA vaccine? Well, it's novel technology for making human vaccines, but the actual technology of manufacturing mRNA is pretty old. We did this when I was in college. I was a molecular biology undergrad, and we did this even back then. So it's a piece of messenger RNA that encodes for the viral spike protein. Messenger RNA is the way that all living cells make proteins. So your DNA is converted into messenger RNA, and the messenger RNA is taken up by ribosomes who make viral proteins. And it's a very short-lived molecule. And there's enzymes inside and outside all living cells that destroy mRNA, right? Because obviously you don't want some chimpanzee messenger RNA to float out of a chimpanzee cell into yours, and then you start making chimpanzee proteins. So these things are degraded by enzymes almost instantly everywhere, which is why they had to surround it with a lipid nanoparticle to keep it from being destroyed once it was in your body. But this lipid nanoparticle fuses with the lipids in your cells. The mRNA goes into your cell. It doesn't go into your nucleus. It just immediately gets taken up by ribosomes, and they start manufacturing viral spike proteins, which are presented on your cells, and your T cells and your B cells come along and recognize them and start making antibodies against these spike proteins and inherent immunity with the T cells, and that's how you develop immunity. And it's a super simple, easy to manufacture and way to create a vaccine. They are different, and they can be developed rapidly. They have delicate genetic material. That's why you need the ultra cold storage, right? Pfizer's -70 C, Moderna -20 C. Moderna's lipid capsule is a little more robust, but they're not easy vaccines to handle from an administration standpoint, right? You can't just put them in a refrigerator and leave them on a shelf. They have side effects. The side effects are called retrogenicity. It's the muscle aches, low-grade fevers, etc. We'll go over that a little bit later. The distribution, again, is kind of challenging because the ultra-cold storage and because these are multi-dose, in an effort to, because of the multi-dose storage or the ultra-cold storage, they tend to package them in multi-dose vials to get the most out there. And they tended to package them, their initial strategies was big lots. So, the Pfizer vaccine came in lots of 975 doses. If you couldn't handle 975 doses, you couldn't receive a lot of the vaccine. And the Moderna was coming in lots of 100 doses. So adenovirus vaccines, these are a little bit older, established technology. There's vaccines against Ebola and all sorts of other things using this technology. In large phase 3 trials, they have preliminary efficacy. It wasn't as high as 95 like the Moderna and Pfizer, but that might not actually reflect the efficacy of the immunization. It's just that these trials were much bigger, there were much less controls, and so it was harder to get tighter data, get tighter confidence intervals around this. So this uses in one case, a chimpanzee adenovirus that the chimpanzee virus is adopted to make chimpanzees sick and not humans sick. It's close enough that it can infect a human cell, but not so close that it can make you sick. And this delivers DNA that encodes for the viral spike protein into your cell nucleus. Your cell reverse transcriptase makes it into mRNA, and then the mRNA goes into the ribosome and the spike proteins are made. So that point, it's very similar to most other viruses that use your own cells to produce viral proteins and stimulate your immune system. And this has the same side effect profile: soreness at the injection site, headache, aching muscles, low-grade fever, fatigue, etc. So where are we on our vaccination campaign? So this is from the CDC. We're in phase 1 right now, where there's very, very limited supplies. All our supplies right now come through our federal partners, right? Distributed from the feds to the states, then to enrolled vaccine providers with the OHA. This is very different from most like flu vaccine providers that, you get from your pharmacy, your doctor's offices, and hospital and healthcare systems can order them through McKesson or Boundary or your normal commercial chains. There is no vaccine in normal commercial chains right now because of the low availability of it. But we're starting to be on the brink of large-scale production. So going into the summer and fall, the feds are telling us we're going to see large-scale production, large number of doses available. And then as we go into phase 2 and phase 3, it'll go from what we currently have, these very focused vaccination pods, into being available through commercial settings and commercial healthcare settings. This is Oregon's prioritization. We have 4.3 million people in Oregon to vaccinate. The Oregon plan differs slightly from the federal plan, and then a lot more people have been moved into phase 1A. So you can see phase 1A now has 4 different groups in it. Operationally, this isn't going to really matter because vaccine availability is still pretty limited. And so even putting more people in group 1A doesn't make more vaccine available. Still, people are still going to be vaccinated in roughly the same order as they were with the federal plan. So this is how we're currently doing with the feds. Here are our current allocations. Remember, in phase 1, distribution of the vaccine is exclusively through the feds. So we have our Pfizer and Moderna numbers as the only 2 approved right now, although Johnson & Johnson has applied for their emergency use authorization for their adenovirus vaccine. Their vaccine comes in single vial doses and does not need to be frozen. It's It's just a refrigerated vaccine, so it should be much easier to distribute. Prime and boost, that just means your first and second shot, right? Both the Pfizer and Moderna are 2-shot combos. The Pfizer, you get 3 weeks apart, so you can be immune 1 month after your second shot. So that's a 1-month series, and Moderna adds one more week to that. So prime and boost is just first and second shot. So here's how we are in our vaccination efforts so far. The little asterisk is we're still collecting data there, so that doesn't, it's not that it's going down, it's that when you administer a vaccine, you have 24 hours to put it in the system, and then they tabulate, not every single day, and put out reports every single day. So that's just a lag in reporting right there. The vaccine numbers are still going up. So we have vaccinated, given them approximately a little over 900,000 doses to 900,000 people. 270,000 got their first dose, about 320,000 are fully vaccinated. So that's about 16% of the population are fully vaccinated in 2 months. We expect supply to be going up, and so we expect these vaccination efforts, especially when it gets into the commercial chain, when Safeway and Rite Aid, et cetera, start getting large volumes of the vaccine, we expect this to go up. And we're thinking we're going to hit the 70%, 70 to 90% of the population vaccinated for herd immunity, probably by the late fall. People ask a lot about the side effects and safety of this vaccine. Those of us that live in the public health world know about the vaccine adverse event reporting system. This wasn't created for COVID. This is for all vaccines in the United States. People who administer vaccines have a mandatory obligation to electronically report both minor and serious side effects. And this is monitored by the CDC, and they put out weekly morbidity and mortality reports through this system. So here's the most commonly reported adverse events and the percentage of them with each vaccine. And you can see they're pretty similar, just as the efficacy for each vaccine is pretty similar, as you would expect, because it's the same technology. So I imagine everybody listening today has had at least their first, if not their second shot. Yeah, I experienced about half of these when I got mine. I did not experience the dyspnea, so that's a British way of spelling dyspnea, or shortness of breath. And here's monitoring for serious side effects, right? To include death. And this is a little bit more interesting because when you look at these side effects, this is just what people said they had. When you look at these side effects, there is actually a complex algorithm to see if the side effect might be related to the vaccine. And it's not this simple, but one way to think about it is, one part of the algorithm is to look at the percentage of the population that has this disease that's not vaccinated compared to the percentage of the population that got the vaccine, and see if there is a signal there, if there's a 90% confidence interval that rate of disease in the vaccinated population is different from the rate of the disease in the unvaccinated population. Now, this data is, this was back in January still, so this is some outdated data. I wasn't ambitious enough to find the latest weekly report, just because it's not the numbers I'm trying to illustrate. I'm just trying to illustrate that we are monitoring for all these things and that there's been no signal yet. And, just to point out, what does that mean? So, back in January, very early on, there was one event entered into the system for acute myocardial infarction in a vaccinated person. But when we look at the events in unvaccinated people, it was 173. And that's what the signal, yes or no, on the right side is can you attribute that bad outcome to the vaccine based on the rate of those diseases in the population? You see here it says, and you can tell this is early data because that was before the first anaphylaxis case had been reported. So I don't want to say that people don't have bad outcomes or anaphylaxis, but it's pretty low. And to this date, there's been no deaths reported due to the vaccine. There's been a couple of anaphylaxis, no deaths, no serious outcomes related to the vaccine, but 500,000 deaths in the unvaccinated. So part 3, never let a crisis go to waste, from our good Dr. Weiner. So what has happened since this began for EMS? So if anybody remembers ET3, it wasn't last year. I seem to have lost an entire year of my life to COVID. So it was 2 years ago, after decades of prodding, the Center for Medicaid Services said, we're going to have a grant program. We're going to call it ET3. And this grant program is going to allow you to treat and transport as usual to a hospital, but it'll also allow you to treat on scene and treat and transport to a alternate destination. There is a very limited amount of agencies that were allowed to participate in this grant. Large agencies like Houston Fire Department, American Medical Response, etc. But it was a step in the right direction and a step we hope would continue going in. Well, when COVID came along, one of our strategies for EMS surge was to not transport people, to treat them in place. And another strategy, as you saw earlier, was to treat them and take them to an alternate destination. So the OHA Start State Medicaid program changed their policies and said, yeah, we will pay you to treat in place. And they upped their reimbursement rate from $54 to $420. What was basically a welfare check or a public assist check to an ALS1 base rate. And you can have a strategy that says, okay, treat in place, but if you can't keep the doors open, then you can't really implement that strategy. So this was a big thing our health systems division did early on, back in the spring, and it mimics what the agencies that can participate in ET3 can do. And the second part of ET3, CMS, not just the state, but the feds, expanded their list of approved destination sites for ambulance transports for COVID-19 patients to include pretty much everywhere. So hospitals, critical access hospitals, skilled nursing facilities, community mental health centers, federally qualified health centers, even doctors' offices, urgent cares, dialysis centers, etc. Another thing they did is early on, we started getting a crescendo of calls from patients that used non-emergency medical transport. So these are wheelchair vans, stretcher vans, etc., to get their routine medical care. So, you know, if you need to go to a dialysis center 3 times a week, if you need to go get your chemotherapy, medical assisted therapy, etc. The vendors of the non-emergency transport didn't have proper PPE policies, procedures in place to deal with this, and so they were refusing the transports. Well, EMS, ambulance services, has an all hazards approach to infectious disease, and so we had the training, decon policies, equipment, everything, and Center for Medicaid Services basically said, yeah, you can do all these non-emergency medical transports. We're going to say that if you have COVID or suspected COVID, you need to be medically isolated, and so you can charge a BLS base rate. And that averted a huge disaster of unnecessary deaths for people that could not get their basic medical needs met. The other thing is the Oregon Medical Board, in their wisdom, realized that in rapidly evolving situations, we might need to change the scope of practice, and that's a process that usually takes 9 months to a year to do. So they made an emergency rule that's been made permanent now, that the Oregon Health Authority's EMS medical director can issue emergency scope of practice changes under a governor's declared emergency. And so far we have done. Early in the spring, when we couldn't get people tested, we issued an emergency scope of practice change, allowing COVID testing from EMT and above. Also, as part of our strategies for EMS surge, we issued a emergency scope of practice change that would allow EMTs to use IM-EPI for asthma, to reduce nebulizer use and reduce the spread of aerosolizing procedures in the back of the ambulance. And most recently, when the vaccines showed up much earlier than we thought they were going to, in January, we issued an emergency scope of practice change to allow EMTs to administer intramuscular COVID vaccines. And those are all on the webpage I showed you. We also, early in the spring, before we had the surge under control, issued an emergency provisional license to allow EMS providers from other states to rapidly get licensed to come into Oregon. We did, as a way to protect our agencies and our ASAs, say you could only get licensed if you were working for an Oregon licensed agency. So you couldn't move your agency in here and stop operating in other people's ASAs. You could only come in here as a provider to work for an Oregon agency. The other thing we did was we rapidly developed a state ambulance contract. State ambulance contract mimics the national ambulance contract in that everything in it is NIMS typed. Ambulances, fixed wing, rotary wing, ground ambulances, ambulance strike teams, ambulance task force. We have some other Oregon booster pack stuff. So we have emergency medical task force, which is basically EMTs and paramedics and supervisors without the ambulance component. So we can send them into a nursing home. Paratransit vehicles, isolation transports, what I had mentioned earlier. So we'll pay ambulances to do non-emergency medical transports. And then also added blood and nasal swab testing for COVID and vaccinations to this. And so we have 2 or 3 big agencies that are right from the get-go has been really saving our collective public health butt. When we had nothing in our medical system where we could immediately issue task force orders and send somebody to any geographic location at any time to work with any population, to do testing and now to do immunizations. And so EMS has been instrumental in the response, especially where the traditional medical system can't reach. So homebound individuals, because of medical frailty, they can't leave their homes, but also other populations that can't leave their homes. So Oregon foster youth, correctional facilities, you're not going to move 200 prisoners to a convention center to get them vaccinated, but EMS is used to operating in austere environments, so they'll go in there and do it. Retirement homes, SNF, memory care, migrant worker camps. When the wildfires destroyed everything down in Medford and Ashland, we partnered with the Mexican consulate to send immunization teams down there for all those displaced workers. So thousands of tests and immunizations given, and it's really been a godsend. So in the last part of the COVID response I want to talk about really quickly because we're running out of time. We've stood up regional hospital collaboratives. So we have 5 regional hospitals in each of our, one in each of our ATABs and one of each of our healthcare preparedness regions. They were initially set up for COVID response, but they predictably found their usefulness much sooner. So when the wildfires hit and we had to evacuate 5 Oregon hospitals, we stood up this regional hospital network. We stood it up a second time for the COVID surge in November when we were running out of ICU beds. And then just recently, the winter storm, we stood it up again, and it's been instrumental there. So the regional hospitals, they match the right patient to the right care at the right time. You know, there's centralized coordination during the surge. That means we have phone calls every day with the 5 representatives from the 5 hospitals to report out on how many beds they have, what their EMS system is doing, what's their capacity, and they are, since it began, they are currently writing them, or they began writing them, but they're currently writing, you know, agreements on triggers, when patients will be transferred within regions, between regions, within healthcare systems, and how they're going to coordinate those transfers and research. Also, regional advice lines. Maybe you can't move the patient, but you need a telestroke or ICU teleconsult. Some of our big centers in the metro area have set those up. So regional hospitals are supposed to have like the 3,000-foot view of what the needs are, where the resources are, and to be able to match the right patient the first time. They're built on natural referral patterns, just as our ATABs are. And they're based on patient flow that occurs because of geography and because of specialized resources, such as specialty resources. And it's really just an extension of it is adding in our healthcare preparedness and surge capability into our existing trauma system. The regional resource hospitals function as bed management and transfer centers. And the regional patient distribution refers to a system by which the regional resource hospitals coordinate with EMS to direct patients to hospitals that have the capacity. So you're managing all the ambulances, all the ICU beds, all the surgeons within your region as one pool, whether they belong to the same healthcare system or not, but only when certain critical triggers have been met. All right, we're almost out of time. The last thing I want to cover real quick to leave some time for Q&A is this. This was 2010. The governor convened an emergency healthcare task force. They studied for 2 years, and then they came forward in 2010 with recommendations. And those recommendations were to regionalize emergency healthcare for all time-sensitive emergencies, similar to our trauma system, and to have all-inclusive EMS systems instead of just ambulance systems. The healthcare task force reported there was legislation introduced in 2011, but it never moved forward. So here we are in 2021 with House Bill 2076 to establish an emergency healthcare program and emergency healthcare system within the Oregon Health Authority. We're calling House Bill 2076 EMS Modernization Act. Not different in concept from the 2010 Governor's Task Force report, but it has all the details in it, where the 2010 report was just ideas. So this act would regionalize time-sensitive emergencies, adding stroke, cardiac, and peds to the existing trauma system. Different from the 2010 report, it would create an EMS mobilization plan, analogous to the fire mobilization plan. And it would also create a comprehensive EMS system and not just an ambulance system. The projected timeline, if this does pass in this 2021 session, would be state plans would be made during 2022. Those state plans would set the groundwork for regional plans, and the healthcare regions would make their plans during 2023, 2024. And the plans would begin implementation in 2025 with continual improvement and quality assurance until I retire. So that's what we have going on this legislative session, and that was a quick review of the 12 months of our COVID response and what to look forward to in the next 12 months. I just want to say EMS has really, in the past 12 months, risen from an obscure little program in the Oregon Health Authority to a go-to partner in our COVID response, whether it comes to testing, immunization, education, reinforcement of nursing homes. We've found several nursing homes during the height of the surge where there was just the staff was all out sick, the patients were all sick. Basically, the place had been completely abandoned. EMS came in, stabilized, transported, staffed the facilities until more staff could begin in. Really, you guys have done an incredible job. I hope you've stayed safe. I hope you all got your vaccination. And I just want to thank you for everything that you've done. And with that, we'll take questions.
All right, thank you, Doc. We only have a couple minutes before the next presentation starts, so we'll just do a couple questions here. Let's see here. One question was, do you believe the flu vaccine will ever be RNA-based, or can it be RNA-based going forward?
Ooh, wow. I'm going to say I don't know. Here is, the difference between the coronavirus and the flu vaccine and the flu virus is that the coronavirus has a single strand of genetic material that can only mutate. The flu virus has 4 different strands of genetic material. And so even without mutating, we can switch strands between variants of the virus, which makes it much more difficult to make a vaccine, because you got to predict exactly what combination of those 4 pieces of genetic material are going to end up in a seasonal flu outbreak. Where the coronavirus, it can just have small point mutations, but it's basically going to be the same virus all the time. And so I don't know if that affects the ability to make RNA viruses, but it makes it much more difficult to make flu viruses through any technique.
All right, because we gotta get the next one started, what I'm gonna suggest, if Dr. Lehrfeld's okay with this, is, I'm sure his email is right there on that last screen. You can email him. I'm guessing, Doc, you don't mind directly any questions you may have that came up today, and I'm sure he will be happy to get right back to you. That being said, thank you all. That is the end of this presentation. Dr. Lehrfeld, any last comments before we go?
Yeah, just thank you for having me. Thank you for all the work you've done in responding to this pandemic, and stay safe, and hopefully next year we'll see you all in person.
Perfect. Thank you, sir.